respected senior professionals and dear friends. So this topic is very important topic. Please listen carefully. So every point is very important, not only for us, for the sake of our family and also our friends. So this is a very big problem now. India and also the world is facing. So what you mean by the obesity? See, obesity is defined as a chronic disease, and it is a progressive disease, and it is a relapsing disease, and also a multifactorial disease. So it influenced by the many factors, could be psychosocial, sometimes a genetic, environmental, physiological, which acts as a gateway to a variety of other non-communicable diseases. So this definitely says that obesity is a multifactorial disease, and most of these factors like psychosocial, genetic, environmental, physiological, I think environmental factors are very important in our Indian population, and it is not only a simple one, it is a very big disease because it gives a way to the several non-communicable diseases like your diabetes, your hypertension, your dyslipidemia, your ischemic heart disease, your CKD, your CVA, osteoarthritis, obstructive sleep apnea, etc. So as I told you that it is a major epidemic of the present century, affects up to 30% of the most Western population. So this is when the time the slide was made. I think now it is almost like the 40 to 45% of the Western population are the obese individuals, nearly 50% of the Western population. It is likely to lead a fall in the life expectancy. That is very important. So the more the obese you are, the life expectancy definitely will be reduced because of the several comorbidities. And most important thing is childhood obesity emerging as a major problem. So more than the 5 years, more than the 7 years, even in the adolescents, in the kids and in the young children, so the obesity is increasing in a big way. So it is a global disease, not only a local disease, it is a global disease, and it is a big health priority. So if you see the prevalence, in the 80s, the prevalence of the obesity is just 14%. But now the prevalence of the diabetes is to the tune of 48 to 65%. A mammoth increase, almost 4 to 5 times increase in the prevalence of the obesity in the last 40 or the 45 years. So that shows the obesity is a very big disease right now, and also is going to be the #1 disease in the near future also. Definitely is a complex disease. So don't think that obesity is a very simple. It is a very complex one, and it is a very progressive in most of our individuals. In some individuals it may be the relapsing, but again it is again progressing. So its up and downs will be there. It is characterized by the abnormal or excessive body fat, that is the adiposity. So we all know that the fat cells are there. They are also called as the adipocytes. And when you are taking the excess calorie intake, suppose you are supposed to take maybe 1500 calories a day. You are taking 1600 calories a day. That means 100 calories excess of your requirement. So the simple excess of 100 calories don't enter into the fat cells. That will be converted into the glycogen, and the glycogen will be stored in the liver and the muscle, and whenever you need it in a simple fasting of about 1 hour, 2 hours or 3 hours, this glycogen will be converted to the glucose and will be helpful for your brain and other tissues. On the other hand, we are taking out of 1500 calories a day, we are consuming 2500 calories or 3000 calories, and more calories we are taking, then that excess calories will be converted to the fats. Fats nothing but here the triglycerides. Triglycerides also called as the triacyl glycerols. So these triglycerides will be stored in the fat droplets. It's a simple droplet characterized by or surrounded by the phospholipids, and that will be stored in the fat. So here, as far as the fat is concerned, two things will happen. One is just increase in the fat cell size. That is, you consider as hypertrophy. Suppose the fat cell is like this, and then it will be hypertrophy. The more and more increase in the cell. On the other hand, most important thing is hyperplasia. That means instead of the 10 droplets of the fat, you will have 50 droplets or 100 droplets. So that means the fat cell not only increasing its size, but also increasing the number if you see the morbid obese individuals. So that's what happens in the adipocytes. So finally what will happen? That impairs your health. So in many ways, from the top to the bottom, all the complications will be because of the obesity. See, the 1 billion people are affected by the obesity, very big numbers. But what here most important is last one, children. See, the adults, nearly the 7 crores, 76 crores, whereas the children, that is also in the high numbers. So what is most important thing here is the greatest number of the people living with obesity are not in America or in Europe or Australia, but they are in Pakistan, India, Nepal, Bhutan, like low and middle income countries, where there is a double burden of malnutrition and obesity. So what are all the diseases we have? They are either because of the malnutrition or because of the obesity. But earlier, most of the deaths are because of the malnutrition, but now the more the deaths are because of the obesity. So the obesity induced deaths outnumber the deaths caused by the malnutrition. If you see the Indian scenario, the obesity affects up to a third of the adult Asian population. So right now, again, that is a old slide, right now it affects nearly 45 to 50% of the Indians. Not the 33%, one third means 33%, but now it is about 45 to 50%, and some places like Punjab, or some places in Hyderabad, or some places in Gurgaon or Noida, so the obesity incidence may be 65 to 70% also. Maybe because of the biryanis or because of the bakery items, etc. So the numbers are rapidly increasing in association with the rising urbanization. So the more the urbanization, the more the sedentary lifestyle, more mechanical life, etc. will definitely lead to more and more obesity, especially software people, etc. Now the most important thing is even children are not in excel because of the high academic excellence, competition, and the school starts from 7 a.m. and ends at 8 p.m. or the 9 p.m. in the hostels, etc. So the more study hours. So no children is allowed to go into the playgrounds right now after entering into the 8th standard or the 9th standard. NEET studies or NEET oriented or AMCET oriented or your IIT orientation, etc. So they are all very good in their academics. At the same time, they are very good in getting obesity and also other diseases. See, in my practice of late, I am seeing a lot of the software population who are settled in Bangalore or Hyderabad, etc., getting the diabetes and hypertension even at the age of 28 years, 32 years, 34 years. Last week I have seen one fellow, young female, working in Pune, presented with the blood sugar of 600. Turns to be second type 2 diabetes. With a lot of acanthosis nigricans, abdominal adiposity, weight is 95 kgs. And just 2 days ago, I admitted one case, one fellow, again the software engineer from Bangalore, with a blood sugar of 850 and HbA1c of 16%. Asymptomatic. So most of the times in the type 2 diabetes, they are asymptomatic. So suppose if you don't admit them and start giving your intensive insulin intensification or your normal insulin, etc., these people will go into the DKA or maybe attacked with acute myocardial infarction or CVA and etc. So this is a very important. So obesity is the prime reason for both these two fellows. They are very obese. Their BMI is nearly 31 to 32. So almost double XL size or etc. So if you see the Indian picture, so this is the very recent one, India study, ICMR, released in the December 2022. See here, 25 crores of adults live with the generalized obesity. 35 crores live with abdominal adiposity. So obesity is linked to the multiple health complications, including heart, that means both ischemic heart disease and heart failure, type 2 diabetes, and certain types of the cancers like oropharyngeal cancers, gastric cancers, liver cancers, pancreatic cancer, breast cancer, endometrial cancer. These are very common in the obese individuals. So coming to the generalized obesity and abdominal adiposity. See, for a given BMI, the women are more fat when compared to the males. And again, if you see the generalized obesity in women, they are more of the generalized obesity because the obesity is more in the buttocks, more in the shoulders, subcutaneous fat, etc. Whereas in the males, it is more in the abdominal adiposity or the visceral adiposity. So visceral adiposity is more dangerous than the generalized obesity. See here, Obesity is associated with 230 plus complications. You can add any number. So 330 plus, yes. 450, yes. 500 plus, any number. So what are all the complications you know so far? You can be attributed to the obesity. That is the importance of the today's talk. See, the more and more are which color? We are very strong. Very strong. See, the grade 4 is the very strong. So that shows the obesity and its complications. See, how we will define obesity? So all these years there are the several definitions of obesity. We know that BMI is the very, very important. No, not at all for our Indian population. So BMI is nothing but weight in kgs divided by height in meters. So that will give you the BMI. So all we know the BMI 25 is the normal, 25 to 30 is overweight, more than 30 is obese, etc. So based on the BMI, individuals can be classified as the underweight if they are less than 18.5, normal weight 18.5 to 23 for Indians, or 25 to the Western population who overweight or the obesity. So this is the normal figures. Okay, so this classification may not valid for the Asian Indians. Unfortunately, even today most of our people, they talk that obesity means more than 30, overweight means more than 25. So 25 to 30 is the overweight, more than 30 is the obesity. But see, so these are thin fat or metabolically obese Indians. So for Indians, the overweight means 23 to 25 and obese means more than 25. So what is overweight for our Western population is obese for us. Okay, so because we have a thin fat, for a given BMI, we are having the more fat when compared to the Caucasians. So these are two types of the obesities, apple shape and the pear shape. So apple shaped means upper abdominal obesity, where the pear shaped means lower abdominal obesity. So BMI does not differentiate between these two types of obesity. So if you see the total weight and height, the both will appear like the same BMI. But if you see who is more dangerous, the apple shaped obesity is more dangerous. So upper abdominal obesity is more dangerous. If you see the BMI, both of them are the equal BMIs because the height is the same and the weight is also the same. But accumulation of the fat is important. The site of the accumulation of the fat is very, very important. So for Indians, this is more important than the BMI. That is the waist circumference. So for us, in the males, more than the 90 centimeters and the females, more than the 80 centimeters is considered to be the obese or abnormal. That is for the Westerns, we add 10 more. So for Western population, more than 100 in the males, more than 90 in the females. For us, this is more important for Indians rather than the BMI. And if you see the waist hip ratio, that is also very important. Waist hip ratio more than 0.9 in females and more than 1 in males is obese. And about the diabetes, see, the major etiological factor in the type 2 diabetes is the obesity, but in Indians, even the type 2 diabetes can occur in the normal weight individuals and also in the lean individuals also. May influence the response to the therapy. Obesity definitely influence the strong bearing on the diabetes complications. So the more the obese, more the diabetic complications like your nephropathy or ischemic heart disease, etc. And weight gain due to the anti-diabetic agents. So certain drugs will also gain the weight in diabetic individuals. So whenever you see a diabeticity, so diabetes and obesity, so better to avoid some drugs, especially OHS, which gain weight. So diabetes is not an isolated disease. Diabetes means vascular inflammation, more weight gain, more hypertension, more fat, adiposity, and of course more insulin resistance. So these are all important risk factors for the end organ damage. So the management of the type 2 diabetes requires a holistic, multifactorial, person-centric approach, especially includes obesity management also. So unless you reduce the body weight in all the type 2 diabetes, if they are overweight or the obesity, the management of the diabetes is very, very difficult. So this is the fat. So this fat will be accumulated in the adipose tissue and also sometimes in the liver. So you consider as the fatty liver. So when the fat in the hepatocyte is more than 5%, it will be considered as the fatty liver. And depending on the stages, you can call them as the steatitis, steatohepatitis, or fibrosis and cirrhosis, etc. So all these fat will have inflammatory mediators like your cytokines, adipocytokines, free fatty acids, interleukins, leptin, adiponectin, etc. So these are all will cause insulin resistance, and also they may damage the beta cells not to produce insulin at all. So that means beta cell dysfunction, maybe because of the lipotoxicity or the glucose toxicity. So this visceral adiposity, free fatty acids from the adipose tissue. So the more and more fat accumulation, free fatty acids, and then it will lead to the ketosis. And insulin resistance is a very important, that is the fundamental in your metabolic syndrome. So that decreases the insulin secretion, decreased glucose uptake, increased hepatic neoglucogenesis and lipid synthesis. This is all because of the insulin resistance. Free fatty acids accumulation, hypertension will occur more, prothrombotic and vascular inflammation. Vascular inflammation recorded by your high CRP levels. Leptin is very good, so the more the leptin, so definitely we will have less appetite. But in spite of the Indians are having the more and more leptin, so we are having leptin resistance. So because of, even though we are having the more leptin to suppress the appetite, because of the resistance of the leptin, the appetite is not being suppressed, and we are eating many things because leading to obesity. So that is another point. And chronic inflammation. So vascular inflammation is a very common in our diabetes management. See the role of the body fat distribution. See the normal picture on the left, and the right one is the obesity. See the second picture, obesity. The fat, where? Surrounding the liver, surrounding the pancreas, where? So all the abdomen is filled with the fatty tissue. So this is the obesity. See the adipose tissue itself is a big endocrine organ. As I told you, the several hormones it is releasing. So they are all leptin, adiponectin, resistin, tumor necrosis factors, interleukins, etc. So these hormones have an effect on your hypothalamus. See our food center or satiety center is situated in the hypothalamus. So this hypothalamus gets the signals from these different hormones. So these all hormones will send you the signals to the hypothalamus. So because of these hormones, so there will be dysregulation of our satiety center in the hypothalamus, leading to binge eating, etc. So that is the reason adipose tissue itself is a big endocrine organ like your pancreas or other organs. So these are all the hormones released from these adipocytes. So this is the etiological classification of the obesity. Sometimes iatrogenic causes, weight gain. Certain drugs will cause the weight gain. I will tell you at a later time. Some people post hypothalamic surgery. So definitely hypothalamus is the center for your satiety, that will be lost and then lead to binge eating. And most important is the dietary obesity. So that's what India is facing right now. Frequency of eating. So 4 times, 5 times, 7 times. High fat diets. So cheap diets, street foods, they are all dense calories. So the cheaper the food, the more the fat. Overeating. So these are the reasons for your dietary obesity. Neuroendocrine obesities like Cushing's, polycystic ovary syndrome, hypogonadism, etc. And some genetics like autosomal dominant disorders like PWS syndrome, Prander-Willis syndrome. So there is an autosomal dominant, very rare. Sometimes that can be seen in some of our population. So some genetic causes also there to cause the obesity. But out of them, 85 to 90% is the environmental factors, that is your dietary obesity. So this is the good slide, shows you the medications common with the weight gain. So these are all the common drugs we prescribe. See anti-diabetic agents, we use insulin. Insulin is an inotropic, so insulin definitely will gain more and more weight. And then the sulfurias, so definitely they keep on producing more and more insulin from the pancreas, so again more weight gain. And thiazolidinediones like pioglitazone, so will increase the body weight to the tune of about 5 to 10 kgs. Antidepressants, so some of the physicians almost they write like a psychiatrist. A lot of the antidepressants, so they cause a lot of the weight gain. And the antipsychotics, yes, olanzapine, so being popularly used nowadays, and risperidone, quetiapine, etc. And anticonvulsants and corticosteroids. So out of them, we often use the corticosteroids and anti-diabetic agents, sometimes an antidepressant and antipsychotics. These are all will cause weight gain. So you have the possible alternatives as per the diabetes is concerned. So preferably, instead of your pioglitazone and sulfonylureas, we will go for the GLP-1 agonists of today's talk. So that will reduce the body weight also. Metformin is a weight neutral. SGLT inhibitors, definitely they reduce the body weight. And antidepressants, instead of the antidepressants, you can use the despirone, etc. Antipsychotics, anticonvulsants, and corticosteroids. These are the important drugs to be used as an alternatives when compared to these drugs which cause the weight gain. So these are all the health penalties of the obesity. So why you are showing a lot of interest in the obesity? Because increased risk of your type 2 diabetes, your hypertension, dyslipidemia, gallstones, some cancers. Already told you what are all the cancers associated with the obesity. Fatty liver, I told you the stages of the fatty liver also. GERD is very, very important. Gastroesophageal reflux disease, echinacea, and then the hiatus hernias. So they are very common in the obese individuals, and definitely the coffee also will aggravate this GERD. In those people, better to avoid the coffee. People with the GERD, and PCOD is very, very common nowadays. 80% of our young girls are having the PCOD because of the childhood obesity. And degenerate ortho, that is osteoarthritis, etc. Not only your knee joints, but also your hip joints and also the shoulder joints, etc. And obstructive sleep apnea is a very, very big problem right now. So sleep studies and BPAP, etc. And obviously the obesity reduction will definitely help in reducing the obstructive sleep apnea. So out of them, the being overweight or the obese at age 40, nowadays we are seeing the obesity even at the age of 15 and 20, life expectancy by 3 to 6 years. So if you are obese at 40 years, life expectancy reduced by 3 to 6 years. What about if you are obese at 20 years? I think maybe 15 to 20 years life expectancy. So these are all the effects of the obesity. So heart cardiologist, lipidologist, hypertensionologist, endocrinologist, neurologist, oncologist, so OBG, and also gastroenterologist or hepatologist. So all specialists, all specialties will be very, very happy if you have more and more obesity. So management strategies, so these three are the very important management strategies: lifestyle modification, anti-obesity medications, and surgical treatment. So now we have all the three. Out of them, which is the better? Not the surgery, not the drugs, but the lifestyle modification. So the lifestyle modification, your adjustments in your carbohydrate, better to reduce the more and more carbohydrates, more and more protein, and more polyunsaturated and monounsaturated fats, less of trans fats, less of saturated fats, more of the fiber, less of the salt, more of the fruits. So these are the very good vegetarian diet or the DASH diet to reduce your body weight. And of course, lifestyle modification means not only your dietary approach, but also your exercise, your yoga, your meditation. So these all will help you. And the anti-obesity medications. So now, right now we have the excellent drugs like your Manjaro or U-Peak. So that is your Tirzepetide, a dual GLP-1 GLP-1 agonist, which can reduce the body weight to the tune of about 20 to 25%. Surgical treatment. So that is was always there, the bariatric surgery. When you are moribundly obese, when your BMI is more than 35 or more than the 40, so definitely you need a bariatric surgery. But with the introduction of these GLP-1 and GIP dual agonists, I think the role of the surgery in the obesity has gone, like your GJ vagotomy for your acid-peptic diseases. When I was an undergraduate or the house surgeon, we used to sorry, you have at least 4 to 5 GJ and vagotomies as the first list, top. Now almost obsolete. The same thing will happen to the bariatric surgery also in the near future after the introduction of these beautiful drugs. So still there is a big target, still there is a treatment gap in weight management options. We know the nutritional medical therapy, we all knew that, but we don't practice it. We know the role of the physical activity, still we don't practice. We have the psychological intervention. This is a very, very important. Behavioral therapy, behavioral adjustments, these are very important for your obesity management. So not only your diet and exercise, your behavioral approach is also very, very important. And then finally you will go to the endoscopic procedures and bariatric surgeries. You see, if all these things, 3 to 5% weight loss and if you go to the surgery, 25 to 35%. What you mean by where is your 5 to 25%? That 5 to 25% is filled by our new drugs, like your Tirzepetide. So that reduces your body weight from 5% to 20 to 25%. So if you need 25 to 30%, definitely bariatric surgery is the answer for that. So what are the targets for the weight loss? Initially target a loss of 10% of the present weight. That depends on the index body weight. Say I have seen one fellow weighing about 148 kgs. So what is your target? Not the 10%. 10% means just 14 kgs. So my target for him is nearly 40%. So I need at least 90 kgs. Ideal weight is about 85 to 90. That means 50 to 55 kgs weight loss is required for him. So that means my target is about 40%. On the other hand, I have seen another fellow with 95 kgs. So my target is just maybe 10 to 15%. So that your target of your weight loss depends on the index weight. So even as little as 5% to 10% weight loss can reduce the risk of the CVD and the stroke. Even 1% of the weight loss is beneficial. Even 5% of the weight loss is good. 10% very good. 20% very very good. 30% excellent. So at least 5% of the weight loss should be gained with your dietary approach or with your exercise or with your drugs. So this is the beautiful slide, shows you 5% weight loss. What are the benefits you are getting it? See, the liver insulin sensitivity will be increased, liver triglyceride levels, so start reducing it, beta cell function will start functioning, muscle insulin sensitivity will increase, so the muscles will take more and more glucose, abdominal adipose tissue good, insulin sensitivity adipose good. So these are the advantages with your 5% weight loss. Suppose if you lose 10%, 10 to 11%, so you get all these benefits. Suppose if you lose about 15 to 20%, you will get the multiple benefits. So as little as 5% is okay, but you should aim for about 15% or the 20% to have very excellent results, not only in your heart, in your liver, in your adipose tissue, and your pancreas and other tissues. So the weight reduction associated with the improvement of the many obesity related complications. See the dyslipidemia. So you will have the good excellent response if you lose till 15%. Suppose hypertension 15%. CV risk reduction, that starts when you lose only 10%. If you lose 5% of the body weight, you may not get the CV risk reductions, but you will gain more if you start losing from the 10% to the 15%, etc. Okay. So again, the modest weight loss can drastically reduce the visceral fat. Even if you lose 5 kgs or 10 kgs, so there is a lot of the difference in your visceral adiposity. So once your visceral adiposity reduction is there, and obviously your inflammatory cytokines also will reduce and will give good quality of the health. So the body weight depends on the balance between your diet and the exercise. So calories spent and calories in the food. So unfortunately, we are more on the right side rather than on the left side. So we should be balanced, your weight, food intake and the exercise. So weight loss diets, lot of the weight loss diets are there in the market. Okay, low calorie diets and low carbohydrate diets. Low calorie diets are high in the carbohydrates, high fiber, low glycemic index, etc. In the same way, very low calorie diets are also there. The commercial preparations, 1 sachet a day. Each sachet is costing about 300 rupees and 400 apples. I asked this fellow, this sachet should be taken before the meals or after the meals? He said, no sir, we have to skip the meals and you have to take this only sachet, 300 rupees worth. Then I told him that if you skip the meal, you don't require this sachet also. So you can save the 300 rupees also. These are all the commercial preparations. If you see the ingredients of the sachet, maybe some maida, maybe some wheat, etc. costing about 20 rupees or 30 rupees. But they will make a beautiful pack costing about 300 or 400. So don't trust those such type of the commercial preparations to lose the body weight. Okay. So this is a very good joke. The only diet shake I recommend, you don't want any exercise, you want diet shakes. So the doctor says that shake your body. Okay. Shake your booty makes when you exercise. That is a good shake, not the diet shakes. So now this is the role of the exercise. Okay, it's difficult to achieve the weight loss with exercise. Don't expect the weight loss with exercise. So exercise will have the many benefits. If you keep on doing more and more exercise, then definitely you can lose the weight. But in the initial days of 3 months exercise or 4 months exercise, so don't expect the weight loss. However, exercise can increase the effectiveness of all weight loss dietary regimens. Exercise is more important in maintenance of the weight loss rather than the initial achievement of the weight loss. Exercise has other beneficial effects and should be recommended for all the patients with the diabetes. So the take home point is, don't expect the weight loss with exercise. Even if you don't lose the weight, if you keep on doing some exercise, that exercise will help you many ways. So the goal for the patients, 10,000 steps per day. So we say that 30 minutes a day, 5 days a week, 150 minutes a week, that is for the Western population. For us, 60 minutes a day, 7 by 7. So these are all the improvements of your exercise, even though don't lose the weight. See here, abdominal obesity, 30% reduction in the intra-abdominal fat when you do the exercise. So it reduces the intra-abdominal fat. Thrombosis, so exercise will act as anti-thrombotic measures. Insulin resistance reduces by 30 to 85% improvement in the insulin resistance. Atherogenic dyslipidemia, so your HDL cholesterol will improve, that is good cholesterol will improve with exercise, LDL will reduce, triglycerides will reduce. Hypertension, so definitely the systolic blood pressure will reduce by about 5 to 10 millimeters of mercury. And systemic inflammation, vascular inflammation also will reduce. So the moderate intensity endurance exercise on most days of the week is very, very important. Not on most days, all days of the week. So what fits your busy schedule better? Exercising 1 hour a day or being dead 24 hours a day. So that means you are not doing any exercise a day, you are dead on 24 hours a day. So this is very, very important too. So pick on some exercise. So now coming to the topic proper. So these are the next few slides are the very, very important. This is what I have told so far is the introduction of the topic. So what you mean by obesity? What are all the consequences of the obesity? What is the role of the diet and diet shakes? And what is the role of the exercise, etc. So now move on to the topic. That is Urpic, that is the Tirzepetide. It is a single molecule, activate both the GIP and the GLP-1 receptors. All these years we are all familiar with the GLP-1. So GLP-1, you have the endogenous GLP-1 that is being destroyed by your enzyme, that is the DP4 enzyme, and you have the DP4 inhibitors like sitagliptin or saxagliptin, veldagliptin, lenagliptin, teneligliptin. So these are all will inhibit the DP4 enzyme so that your GLP-1, endogenous GLP-1 will be there in the body for a longer period to have the proper effects. But now the concept is more towards the GIP. So GIP and GLP-1, these two are the incretin hormones being secreted from the small intestines with your food in the mouth. So whenever you see the food, whenever you eat something, so immediately it gives signals to the small intestines to release these two hormones. So these are the very, very useful hormones in the body. And if you use these drugs, dose adjustment is not required for the CKD and also the hepatic impairment. So even in the hepatitis individuals, even though when the bilirubin is more, when the SGPT is elevated, or when the creatinine is more, you can safely use these drugs because they are neither cardiac, nor hepatic, nor renal toxic drugs. So they are supportive drugs. See, this is a very important slide, shows you the activity of the GLP-1 and GIP. All these years I told you several things about the GLP-1 activity. See, first concerns the GLP-1 activity. So if it acts on the central nervous system to reduce the food intake, so that is good. Increases the satiety, that is also good, but increases the nausea. In the pancreas, increases the insulin secretion, so how it reduces the blood sugars, and reduces the glucagon, so that is also good because glucagon is antagonist to the insulin, so that also will reduces the blood sugars. Stomach, delayed the gastric emptying. So these are all the good activities of the GLP-1 activity. So that's what we are getting here from you by prescribing your gliptins or your DP4 inhibitors. Now the focus on the GIP activity. So this GIP activity in central nervous system reduces the food intake, decreases the nausea. Adipose tissue, see this also acts on the adipose tissue. That's what we want. By acting on the adipose tissue, your fat cells will reduce. So increased insulin sensitivity, increased lipid buffering capacity, increases the blood flow, increases storage capacity, and reduced pro-inflammatory immune cell infiltration. So when they have the reduced pro-inflammatory cells like your tumor necrosis factor, interleukins, etc., so definitely the vascular inflammation also will be reduced. In the pancreas, increases the insulin secretion and increase the glucagon in a glucose dependent way. See here the two things, they are antagonists to the each. If you see the GIP activity, they decrease in nausea, whereas the GLP-1 increase in nausea. So by using these synergetic effects like for amlodipine and atenolol, amlodipine causes tachycardia and atenolol will cause the bradycardia, and that will be nullified and the heart rate will be the normal. The same thing happens here. So one causes nausea, one causes reduced, and that will be nullified. In the same way, glucagon also. So one increases the glucagon, other one decreases the glucagon, that also will be nullified. So this is the synergetic action of this GIP and the GLP-1 activity. So this is the study named the SURMOUNT. You have the SURMOUNT 1, SURMOUNT 2, 3, 4 and 5. So they compares about the placebo, they compares about the intensive lifestyle programs, and the last one is the SURMOUNT 5, they compared the semaglutide. So semaglutide is extensive GLP-1 receptor agonist. We have the oral forms and we have the several CMEs in Sarovar, that is the Ribelsus, and also we have the injectable. Last time we had one CME with Wegovy, so that is an injectable semaglutide. See the treatment period, all they have taken more than 1 year. So don't expect these trials with only 5 weeks or 6 weeks or 1 month or 3 months. So more than the 1 year or more than 1.5 year studies. See the efficacy. In some individuals, they have started with the 2.5 milligrams. So see all these injections, they are available in India in the strengths of 2.5 milligrams. First week, 4 injections, once in a week. In the second month, upgrade to the 5 milligrams. Third month, 7.5. Then 10 milligrams. Then 12.5. Then 15. So up to 15 it is available in India. In US, they have gone up to the 25 mg also. Okay. So 25 mg per week. So right now we have to start with the 2.5 and don't expect weight loss with the 2.5. That means first 1 month you don't expect any weight loss because there is only to sensitize our body. Weight loss starts from your 5 milligrams and 7.5 milligrams and the 10 milligrams. Okay. So in some cases they have gone up to the 15 milligrams and keep on using for the 72 weeks. In other cases they started with the 2.5 milligrams and reached the 10 milligrams and then continued. In some cases they started with the 2.5 mg, second month they started with 5 milligrams and continued for the so many weeks. So what will happen, we will explain. So some people on the 15 milligrams, some people on the 10 milligrams and some people on the 5 milligrams. So this is the difference. So the first one 2.4 is the placebo and 16% weight loss is because of the 5 milligrams continued for about 72 weeks, and 21% weight loss is with your 10 milligrams and 22.5 is with your 15 milligrams. So this study clearly shows that if you want more and more weight loss up to the 20%, you have to go up to the 10 milligrams or the 15 milligrams. See here, more than the 6 of the 10 participants achieved more than 20% weight reduction with this. 4 in 10 participants taking the Uripic 15 milligrams, weight reduction up to the tune of 25% at the 72 weeks. A large majority of the people lost weight with these drugs. See, body weight reduction was observed in the 96%, 90.7%. So almost all the population we are giving this drug, they are reducing the body weight. Participants taking the Uripic experience the reductions in the weight circumference at the 72 weeks. The weight circumference is also reducing. In the third month and the fourth month, their weight circumference is reduced by about 10 centimeters, 15 centimeters. So that is also possible. So earlier their fat sizes are 40, 44, etc. Now they have come to the 36, 38, 34. So that is also possible. So lot of the weight reduction is seen with your reduction of the weight circumference. This is very important for Indian population because our obesity is mostly the central obesity or abdominal adiposity. So by reducing the weight circumference, we are reducing the visceral adiposity, which is more vascular inflammatory one. So see the here 19.9 centimeters, nearly 25 centimeters reduction in the waist circumference is possible with these things. So systolic blood pressure reduction, obviously once you reduce the body weight, obviously all the things also will reduce. So once you reduce the body weight, obviously the blood pressure will also reduce, your cholesterol will reduce, etc. See, HDL cholesterol will increase, LDL cholesterol and triglycerides also will reduce. So weight reduction in the URP compared to the placebo, reduction in the total fat mass, reduction in the visceral fat. So this is the against your semaglutide study. See, at 72 weeks, participants taking the URP, that is your Tirzepetide, experienced a mean percentage body weight reduction of 21% versus the 15.4% in those taking the semaglutide. So semaglutide also will reduce the body weight to the tune about the 15%. If you want much more, it is about 21% in the Tirzepetide, that is a URP injectable therapies. So the same thing here. So safety wise, so very safe. So in my practice experience, I have given nearly 150 plus people, but only 2 people are stopped. One fellow got very high incidence of the diarrhea, loose motions. So after initiating it, next day about 8 loose motions, and the third day about 12 loose motions, and the fourth day about 15 loose motions, and admitted and given RL and etc. Only fluids, and then subsided and stopped taking them. And another fellow got the severe vomitings. So out of 150 plus, 2 people were dropped because of the diarrhea and the vomitings. And all other people, they are very comfortable with this therapy. Some people will have a little nausea, maybe 1 or 2 vomitings, or maybe 1 or 2 increased frequency of the loose motions. Otherwise, it is very safe drug. Same. All people will have to start with only 2.5. So for the 2.5 milligrams, they have developed this. So then we stopped using these drugs. And other people, they are all female. Some of the patients right now, they are on the 15 milligrams. So that means 2.5 for 1 month, 5, 7.5, 10, 12.5, 15. So they are all in the 6th month of the therapy. They lose nearly 20 to 25 kgs. So these are all the side effects I already told you. Mostly the gastrointestinal side effects. Say nausea, vomiting, diarrhea. So discuss with your patients that may cause some side effects. So before starting these drugs, 2 things are very important. One is the pocket. So you don't gain any gain if you take only 4 injections or 8 injections, 10 injections. So I told them clearly that you need at least 40 to 50 injections a day. Sorry, total course. So that means it's almost like 1 year. You plan accordingly. If you have if you are fit to spend that much of the money, it is worth trying it. Otherwise, 1 month, 2 months, 4 injections, 8 injections, 12 injections, not of much use. But in my clinical experience, I have seen very good results even after the 3rd month or the 4th month of the therapy. So these are all the dosages. Same I already told you. So after this, we have the few surgical managements, also bariatric surgeries. So there are the different bariatric surgeries. Some benefits, if you want excess weight loss, so definitely this helps a lot. There are certain problems in the bariatric surgery. So these are different steps, and sleep hygiene is also very important. So thank you very much for your patience here.